comes from across town, from Children's, and longtime friend and spouse of a friend, and so I'm so happy you're here. And I will say that you're famous with that book that so many patients of mine praise and say that they want to meet the person behind the book. So here's a chance.
Wonderful. Thank you so much, Gloria, and I'm delighted to be here. For those who don't know me, so September was actually 20 years that I've been involved with the clinical care of children who have impairment of the nervous system. I've cared for children with really the whole variety of both disorders and diseases. I had practiced at the University of Minnesota for many years, as well as at Gillette, which is in St. Paul, as well as the University of Minnesota in Minneapolis. So I saw many children with different leukodystrophies. I certainly want to acknowledge that of the different leukodystrophies, there's different degrees of symptoms that are experienced. What I'm going to provide is really a general overview to help think of it as a construct of how to approach particularly children who aren't able to indicate if they're experiencing symptoms. And I have to go with a general overview given that there's just too few studies that have looked at individual diseases. Yet what I found over the time is that the general constructs end up being applicable to any underlying disease. So the way I have this organized, oh, thank you. Oh, there we go. Oh, there we go. So the way I have it organized is that I'm going to just start with an overview of identifying pain, what are causes of pain, and then our interventions, and if there's a little bit of time, just a few comments about intractable symptoms. And as everyone else has done, certainly informal, if you have questions that arise as I'm talking, just raise your hand. And I'll also acknowledge I love the sensory participation that we did. There won't be pain participation. We'll be asking you to replicate pain yourself or your neighbor. So the gold standard of identifying pain is self-report. Obviously, there are many children who are unable to indicate if they're experiencing pain. Fortunately, in the past 10 years, there's increased recognition and awareness that there have been some wonderful work looking at identifying what features can we observe when a child who's unable to indicate to us that they're experiencing pain, and that child has underlying impairment of the central nervous system. Most of it is fairly self-explanatory. This really highlights and summarizes the categories of features. One of the common ones obviously would be a change from baseline with increased vocalizations, particularly moaning or crying. A change in baseline facial expression, and the most common is a very specific type of change called facial grimacing, where tightening of the face, clenching of the mouth, kind of more scrunching of the eyes. The opposite is some children, particularly those with more significant impairment, will actually show a change where they have a very blunted facial expression. But again, it's that change from baseline. The inability to be consoled, a change in baseline interactivity, so a child who appears more withdrawn, having physiological changes, so our heart rate goes up when we're uncomfortable, you can get pale and sweaty. And then I highlighted kind of the conundrum for individuals who have underlying increased tone. So when an individual with impairment of the central nervous system is experiencing pain, just like any of us, you tense. But if you have that underlying baseline increase in tone, not surprisingly, you'll see changes from baseline in movement of the extremities, change in tone of posture, so you can see a child who's arching more, stiffening of the extremities, or flexing of the upper arms, or the hands getting very tense and fisted. And then occasionally we'll actually see children who will show more idiosyncratic features, and one of the more common, though not common to see, is where a child might laugh. So that was just one slide to overview the identification. Again, there could be questions if I can help with that. But I want to switch to the concept of when a child or an individual is displaying those pain features, the categories of pain to consider. And at its simplest, if you just remember that it breaks down into injury of tissue or inflammation of tissue in the body is the one source of pain, and the other source would be alterations in the nervous system. the basic breakdown in pain is nociceptive pain, which is that tissue injury, or neuropathic pain, which is indicating underlying alterations in the nervous system. This looks a little bit busier, but you see that I have it a little bit more detailed, that the somatic pain is just another category of saying that nociceptive pain, or again, tissue injury, versus these other specific categories that essentially are categories due to underlying impairment of the nervous system. And I'll go into each one very briefly in a couple of slides, so I'll get back to that. But I think that general concept will always serve you well by just remembering it's essentially the category where we can test for it or do an empiric medication trial directed towards the problem. So it'd be the bone fracture, the bladder infection, acid in the stomach that's refluxing up and irritating the esophagus and causing inflammation. So again, things that we can test for versus the underlying impaired nervous system that can be a source of symptoms. Just some other general principles related to that. Features of neurological problems include pain behaviors, and you'll see this again in a couple of slides. In addition, remembering that there's always a risk for several problems due to the impaired nervous system coexisting and contributing to symptoms. And then pain from any source can worsen the neurological problems that in and of themselves can also be sources of pain or produce those pain behaviors. I just wanted to show a slide of a brain to get at, again, that concept of if one problem in the nervous system is a source of symptoms, there's a risk for other problems to exist, and to just briefly go through these categories of involvement of the central nervous system and how they can produce symptoms or be identified because of pain behavior features. And as you can see, I'm focusing on this purple area in the central nervous system. This is the area that has a few areas that are involved with important regulation that, when impaired, can produce symptoms that I have been starting to go through. So starting with the basal ganglia, that's the area of the central nervous system that is involved with control of movement. If it's impaired, it results in abnormal movement or posturing, referred to as dystonia. Also in that area is the thalamus. That's the area of the body that receives the sensory transmission from the body. If that area of the brain is impaired, it can result in central neuropathic pain, so a form of neuropathic pain. And then finally, the hypothalamus, that's the area of the central nervous system that regulates the autonomic control of the body, the control of things like heart rate, the dilation of blood vessels to really control cooling of the body or retaining heat in the body, as examples. So when that area of the brain is altered, that can result in autonomic dysfunction, which is also referred to as dysautonomia. Just to go through that briefly in a little bit more detail, central neuropathic pain, again, that was the area, if the thalamus in the brain is altered, can result in central neuropathic pain. This is the one area that's least recognized in pediatrics, but we have increasing recognition based on literature in adults who are able to describe to us symptoms they're experiencing when they have impairment of that area of the brain. The two categories that have been best studied are adults who have had cerebrovascular accidents, so have had strokes, or adults who have multiple sclerosis. Symptoms that they'll describe include neuropathic-like symptoms that are shock-like, you know, like if you've ever hit your funny bone and the symptoms that you get with that. In addition, along with some underlying constant discomfort, they can also describe sudden, out-of-the-blue, shock-like symptoms that occur. And then finally, another area that's so relevant to some of the children is symptoms related to the GI tract, and it's due to a lower threshold to symptom generation due to just normal distension within the stomach or intestinal tract. So what can be described is painful symptoms just related to that normal type of distension. I do also highlight visceral hyperalgesia because sometimes this is a term that ends up being used. Visceral hyperalgesia specifically is indicating that there's been an alteration to the nerves that transmit sensory input from the GI tract to the brain. Sensitization of those nerves can result in visceral hyperalgesia. the symptoms of visceral hyperalgesia overlap with what I described as central neuropathic pain, which is that discomfort related to distension of the GI tract. It's not important to make a distinction between the two because, again, it's just indicating that there's an alteration in the nervous system, in one case in the central nervous system and the other in the gut. Autonomic dysfunction, also referred to as dysautonomia. Some of the features are indicated there. Facial flushing or flushing in other areas of the body. Again, that gets at that regulation of the blood vessels, that if it's dysregulated, you can get vasodilatation within that redness that is seen on the skin, sweating, increased body temperature intermittently out of the blue. And there can also, once again, this theme where there can be GI symptoms of GI pain or a sensation of nausea or vomiting. And then I also just wanted to acknowledge dystonia because it gets at that theme of that area of the central nervous system that if one area is involved, there's risk of another area being involved. Dystonia, by description, is indicating an individual who has alteration in muscle contractions with twisting or repetitive movements or changes in body position. The biggest reason I wanted to indicate it is this term paroxysmal autonomic instability with dystonia. It's a term that is applied for some children who have a constellation of symptoms. Essentially, what it's indicating is that it's an individual who is showing features of dystonia as well as showing features of autonomic dysfunction. And then finally, spasticity, which is a common problem to encounter. Spasticity at baseline isn't always painful. It can have associated intermittent painful muscle spasms. But as important to recognize is that pain from any source can be a trigger for alterations in tone intermittently. And we've kind of been discovering this in retrospect in many ways, that the more we think of treating problems like central neuropathic pain, the more that we're seeing intermittent episodes of muscle spasms and toning, or that extension of the arms or the back arching, lessening in some children more than just treatment directed at spasticity. So the take-home message from this is that pain can trigger muscle spasms rather than muscle spasms solely being the cause of pain. So it kind of gets at that chicken and the egg. This small case series just highlights that point a little bit more. This happens to be 22 children who all have significant impairment of the central nervous system due to various underlying etiologies and causes. All have persistent pain behaviors despite most of them receiving treatment for spasticity and all receiving treatment for gastroesophageal reflux disease as common reasons to consider underlying discomfort. But as you can see, 86%, so 19 of those 22, despite those underlying areas of treatment, have frequent intermittent alterations in tone that are noted and that lessened after treatment of neuropathic pain with the medication gabapentin. And as you can see in the final point, that almost all of them were on one or more medications directed at treating spasticity. So again, just a reminder to, again, remember that spasms aren't always the cause of pain. Sometimes they're the indicator of other sources of pain. So back to general principles, if pain behaviors are identified, again, always starting with assessing for those somatic sources of pain, or that category called nociceptive pain. So looking to see, is there an underlying bladder infection? Is there a bone fracture? Is there gastroesophageal reflux disease to treat? For symptoms that persist or are more chronic in nature, though, the important part and consideration is the CNS sources of those symptoms. So again, the central neuropathic pain, the autonomic dysfunction. And then that will help identify medication trials that I'll just briefly summarize. And then also I'll use a case example just to highlight also thinking of triggers that can worsen symptoms. I'm not going to go through the medications. This is really intended more as a resource, and there's many resources that can actually be accessed even on the internet to summarize this. Instead, I just want to highlight a few points. Given that we don't have studies to indicate with certainty which medication trial is more effective than another, some general principles can be applied. One is always identifying what is the safest medication option and what do medications theoretically treat. So I do have this specifically ordered by starting with medication categories that have low side effect profiles, so are generally considered fairly safe, and theoretically treat a number of different problems that can be sources of symptoms. And then just kind of working down through that. In addition, another principle is how frequent do symptoms occur? For some children, they actually can be intermittent, where when an episode occurs, using a medication as needed, such as using an as-needed benzodiazepine or an opioid or clonidine, can be adequate to manage the symptoms chronically. For other individuals, they'll be frequent enough that it would make better sense to have a scheduled medication so as to attempt to prevent the frequency and severity of the episodes from occurring in the first place. And then again, if there's questions about that specifically, happy to answer. This is just another reference going through that same point, specifically now thinking in terms of persistent pain behaviors and just a graded approach by thinking what step makes best sense. So the gabapentinoids like gabapentin and pregabalin, which medications might be beneficial as an add-on if there is benefit from the first medication trial but not sufficient benefit. And obviously having access to experts with experience with different medications to use. And then in addition, I do want to acknowledge that there are non-medication interventions for spasticity specifically that I'm not spending time on because I tend to find that people are more familiar with spasticity treatment options. In addition to medications would be things like Botox and intrathecal baclofen pump. And again, if there are specific questions, can talk about that. But I do think one principle is if spasticity has associated pain behaviors, pursuing medication trials before pursuing invasive interventions, just to assure that the non-invasive interventions have been maximized. And then the role of therapy, orthotics, and different aspects of managing that chronically. And then just a little bit more on the non-pharmacologic strategies. A lot of times parents become fairly adept at thinking of things. And I have to say I was struck by your comment about having your kids step on your legs. That actually makes sense. That, like the vibratory stimulation here, there are modalities that can be utilized that kind of override the symptom that a person doesn't want to experience. One modality that's used in the younger infants who have a lot of irritability is using weighted blankets, using vibratory stimulation, and then certainly equipment that maintains an ideal position that's most comfortable for the child. And so I find that having a good working relationship with therapists who have familiarity with equipment, and then I know that a lot of times it's what parents share with each other in terms of what they have found to be a really useful resource for their child. And then I want to spend just a few minutes on a specific trigger, and it's that trigger I mentioned earlier of distension of the gastrointestinal tract. Again, if an individual has involvement of the thalamus, so they have central neuropathic pain, or if they have autonomic dysfunction, or if they have visceral hyperalgesia, all of those entities can decrease the threshold to symptom generation from distension in the GI tract. So anything that can lessen distension can also be beneficial. So the most common one that I can see is a parent might notice a pattern that prior to a bowel movement, their child's irritability will significantly increase, and then after a bowel movement, it'll lessen. So that can actually be used in care plans so that if it's a day with increasing agitation, if a child hasn't had a bowel movement, then to use an intervention such as a suppository to help lessen the distension that might be triggering the symptoms at that point in time. And then one other area that there's increasing recognition that's also important, and this is relevant specifically for children who have feeding tubes where they're dependent on us to help identify what would be a reasonable amount for feeding. Obviously, in individuals who are self-regulating that's not what I'm referring to. But what we're really recognizing is that a lot of times, even with the calculations we now use to help guide our determination of amount to be giving, sometimes that can still overestimate the volume of formula and the volume of water that is needed. And so a lot of times we actually find that if we do a trial of decreasing the amount for a time period while also monitoring weight and then being a little bit more circumspect about what's a reasonable weight for a child to have, some children will actually have some reasonable symptom benefit from that. So second to that is if an individual has a significant decrease in the expenditure of energy and then how much calories are needed, that also has an impact on water amount that's needed. When we calculate required fluids, it's based on weight, and weight is an estimate, and the estimate is for individuals with a normal metabolic expenditure. So if somebody has a significant decrease, what we estimate as fluid need, or some individuals can actually overestimate the amount. So again, when we are doing trials of decreasing either fluids or formula, a lot of times we're determining what is beneficial for that child. It's not actually reducing it, it's more determining an appropriate amount for that individual child. And those are kind of some of the reasons behind why that can be both reasonable to try and beneficial for a child. So to wrap this up, I want to end with one last point. So this is a 2-year-old who is indicated to have leukoencephalopathy, but without a specific diagnosis, but it's based on the head MRI findings on several studies. And 3 months following a feeding tube placement, there was persistent irritability that didn't improve despite interventions like treating for gastroesophageal reflux. There's a gabapentin trial with significant benefit for several years. In addition, one concept is, given that the central sources of symptoms, since we can't fix nor remove them, there's still always the risk for breakthrough symptoms intermittently to occur. So for care teams to work with families to be creative as to what are guidelines for in the moment that are going to be helpful, especially to translate that to any home nurses so that they have guidelines also. Through trial and error, what's really identified for this child is most of the time by just identifying simple interventions and attending to that issue of if there hasn't been a bowel movement in a day that uses suppository, the majority of times within 15 to 30 minutes the episode will resolve. Averaging once a month, there'll be breakthrough symptoms that don't resolve with those more simple interventions, and so then guidance on using an as-needed medication. So now we're several years out, and this specific child has a significant respiratory illness and is admitted to the hospital. What was surprising is after the respiratory illness resolved, there was persistent, significant agitation or irritability, but really these persistent pain behaviors after this illness. There was no improvement with intravenous morphine at increasing doses. So an add-on medication is started, nortriptyline in this case, with significant benefit for about a year. And then some increased symptoms again a year later, adjustment of medications with benefit and consideration of adding methadone. And really what I wanted to highlight with this is that, again, when the central nervous system is the source of symptoms, there's always a risk for them to escalate again. Sometimes it's just a need to adjust medication doses because of weight gain. But an important concept that is helpful is always remembering, since the source can't be removed, there's that risk to return. And I like to use this diagram just as a reflection that whenever there's a new escalation in symptoms, it always goes back to those same principles of first looking for what causes can be identified and treated and therefore removed, what triggers can we consider and intervene on, what medication trials can be utilized, and throughout that process always hoping for as much benefit as possible. Most children will have some degree of benefit, if not significant benefit, while also recognizing that not every child will have the degree of benefit that we would hope for at that point in time. So just in summary, pain behaviors can be due to the impaired central nervous system. more than one problem can coexist in a child with that impairment. The treatment that is used, specifically medications, is empiric, meaning it's trial and error. Symptoms due to the central nervous system have a risk of being more persistent and of returning, and fortunately we have a lot of modalities we can use to assure that a child is as comfortable as possible throughout their lifetime. So thank you. I hope that was helpful. Questions that I can help answer?
Great, that was fantastic, Julie. So just shows some of the complexity also in the relationship between pain and spasticity and also our GI system.
Yes.
And often I think the vicious circle we get into, maybe you can speak a little bit to that as we are ramping up treatment for pain, and once we move into baclofen or methadone and maybe slowing down the gut, and now the vicious cycle begins. And how do you deal with this, or are there certain tricks of the trade that you employ in this setting?
Yeah, there's a couple of things. One is that, interestingly, in some children, when symptoms are improved, gut function also improves. It's so the worry of the gut motility being worsened by the medications that sometimes do slow the gut, like you brought up methadone specifically, or baclofen, they end up not being as problematic to manage as I anticipate. Secondly, I think it's always beneficial to, when there's a risk of worsening gut motility, of actually kind of ramping up the bowel meds a little bit, so kind of pushing that a little bit further, and because you can always, it's easier to back off than try to get on top of when that's gotten a little bit out of hand, if that helps. So those are kind of the first thoughts that come to mind.
So you spoke mostly about children, and
yes.
And so of course we're also thinking about a large adult population in leukodystrophies and AMN in men and women, and the fact that actually spasticity, pain, and bowel symptoms are coexist, and I guess it now raises also maybe more of a question in my mind of how much those are interrelated, and how much pain might be contributing to this motility in the bowel. Is that your experience? Do you have any?
So I wish I could. I apologize. I'm unable to speak to AMN directly. I do see adults, but the adults I see are children who have lived past their life expectancy, who have pretty significant global impairment to the central nervous system. So I have experience with adults, but not with the AMN specifically. But I would suspect the general principles would apply. What I couldn't help but wonder in AMN specifically is if there have been individuals who have used things like TENS units to see if that helps with some of the symptoms. It would be one example. Compression stockings, I would wonder again, because it's this concept of you're introducing deep pressure to override the other pathways of sensory input to the central nervous system. It just would be some thoughts that would come to my mind.
What is the danger of drug dependence? Ask.
What was that?
What is the danger of drug dependency?
So in terms of opioids specifically, it's clearly always an important aspect of consideration. There's always importance of recognizing two components to it. One is the physical dependence. So it's always knowing what are we treating, how long are we treating it for. My apologies. Does it make sense to do a brief trial with an opioid while introducing other medications that might be targeting reasons for symptoms, or again, getting to the neuropathic symptoms, making sure if someone's on an opioid for a time period to do a wean so that you don't create that physical dependence, and then the psychological dependence is the greater issue. And so ideally, there's a good relationship with individuals who have expertise in the management of the medications, which is the most important aspect. But I do think that a big part of it is consideration of all of the other medication options that exist for pain treatment, because that can often lessen the need for how much chronic opioid use is beneficial for an individual. Yet by the same token, we know that when it helps, you don't want to shy away from something due to worry of a potential problem.
Great, that was fantastic, Julie. Question over there.
Hi, that's a fantastic talk. I just got a quick question, in that I have a very symptomatic son, and a lot of what you were saying I was thinking yes. Now, I've always urged sort of on caution with things like opioids because of the risk of sort of decreased respiratory effort. Is that something you've seen, or?
Surprisingly, no. Now, there's a couple of caveats. So one concept that always helps, though, is if you think of if there's a symptom being generated, it's targeting receptors that are then creating the symptom in the individual. So when the simplest to describe is if you have a cut, you have normal pain response being triggered, and it triggers certain receptors. When opioids are used, it blocks the receptors that are transmitting that symptom, so you're lessening the experience. So what I mean by that is when there's pain, or the other category it's used in is dyspnea, what you're doing is you're blocking what already exists. Just starting at a lower dose than would be a typical starting dose for either dyspnea or pain, and then increasing it up in a very standardized manner will help determine the appropriate dose for the child. So what I can say is that I've been doing this for 20 years. When I first started, we weren't using symptom meds like we now know and can use. And I have not had problems with opioid use ever in a child with neurological impairment. I know that might sound a little bit dramatic to say, but the more I use them in specific circumstances, the more I'm quite struck at how if a symptom exists and it helps alleviate that symptom, that you're not going to have that respiratory depression that everyone worries about. And there was one other point. I'll think of it. The one other point is that when it comes to the impaired central nervous system, what is striking is that not every child who has these severe pain behaviors, like this case I gave, will have benefit from opioids. All I can speculate, because this is not a well-understood phenomena, but all I can speculate is that really is telling us that it's all of those other aspects of the impaired nervous system that are generating the symptoms, so the medications that are targeted at those specific types of problems. So it's not the traditional pathway of pain generation and why the opioid is not helping it. But also strikingly is in that circumstance, you can use increasing doses and not, again, see the respiratory depression. You just might not see the benefit from it. I hope that helps. And then the final category where I've been using it a lot more is children who have recurrent respiratory illnesses and during the episodes the significant distress, and so that parents are left feeling like they either have to choose to have their child intubated or choose to have their child comfortable until they die. This realization there's definitely a middle ground, and often for years in children, of both treating with antibiotics, maybe with non-invasive ventilation or maybe not, but also alleviating the symptom with opioids like morphine, and great benefit in that circumstance consistently. And again, I can talk more about that if that helps.
So I have a quick comment and a question.
Yeah.
Julie did not ask to have her book put up there. I put it up there. It's a powerful, powerful book, certainly for the professionals in fluoride. You referred to this earlier. And you all can understand every word in there, but I've got to tell you, for the families that are partway down the journey where they're starting to discover all of the challenges, Julie's done, Dr. Hauer has done a wonderful job of organizing that in a way that the families can actually take what you may share in your doctor visit, your office visit, and go home and learn about that or start to discover. So there's a lot of good information in there. So sorry for the shameless plug for you, but it's worth it. Can you comment about cannabinoids and
Yes.
you know, there's a lot of parental interest in all
Yes.
of that as well.
So the category of cannabinoids, the synthetic forms have been studied in adults with MS with clear benefit. Medical marijuana, which would obviously have cannabinoid within it, would then therefore have theoretical reason for benefit. In general, what I'm struck by in looking at the little bit of information that we have is that when cannabinoids are considered for the category of seizures, is that how it will probably play out is that it'll be more beneficial for children with specific genetic types of seizures. So the one that's in the lay press that's most well described is Dravet syndrome, which is it creates a specific channelopathy. What that means is that it's not due to an injured brain or a disease that's altering the function of the brain over time. It's a very specific condition that can generate the epileptic events. And so it can kind of make sense why it might be beneficial in certain circumstances, but I suspect what we'll find is that circumstances that have more global impairment of the central nervous system, just like with other seizure meds, it's going to be hit and miss, not as beneficial. We will probably find that it has benefit for pain. My general approach is the same as the American Academy of Pediatrics, which is, given that it also has some questions as to long-term impact, that it's always best to take a circumspect approach. I don't think we'll find that it's the definitive answer. I don't think we'll find that it's any better than the other options. But since it is empirical treatment, I also won't be surprised if we'll find that some children, just like with the other meds that have been considered, might have particular benefit from that category of medications, just like I have some children who their symptoms will melt just from gabapentin alone, and others who end up being on 3 medications. So again, I don't doubt that it's going to have a role, and then it's going to be dependent on where you live, what state, what country, access to it, and it is obviously the biggest part of it. So I hope that gives some, yes?
I'm just curious with the cannabinoids. I've seen a couple videos several years ago, one of a guy, I don't know if he had epilepsy, but he definitely had a lot of like seizures, and when he would talk, he would be very stiff.
Yeah.
But then they showed him smoke,
Yep.
and he was fine.
Yeah.
Are you dealing with THC or CBD, or which cannabinoid, or is it just the whole group of them, or?
The CBD is what's coming out of the 2 components of the cannabinoids, is what's coming out is seeming to have a greater benefit. Yeah. And that's what is being looked at in terms of some of the, whether it be the synthetic formulations or medical cannabis that is being formulated. But again, from a test standpoint, there's too little information if we were to be the scientists saying from an evidence standpoint. So, you know, you're never going to argue with an individual indicating their benefit. You know, God bless, because who lives with symptoms knows that they, you know, everyone deserves the best, you know, quality of life possible in the confines of, what I know I'm always looking to do is give a balanced description that, just like anytime I see a new seizure med come on board, I'll see all my patients get prescribed it, I'm exaggerating a little bit, and then the kids I care for, in general, you don't see any greater benefit, but with isolated examples of some that it seems to be truly the answer. And my simplistic way, and Florian's much more brilliant from knowing the nervous system than I do, but my simplistic way is there's all these receptors, and the cannabinoid receptors are one of the types of receptors in the central nervous system, along with some of the other medications that target other receptors. And the greater the involvement of the entire nervous system, not surprisingly, you tend to see an individual being on 2 or 3 medications. some less, some more. So what I am excited though is I don't doubt that we're going to find that this will be added to our toolkit of options, and it'll also help take away some of the demystifying of it and do it in a safe way, which is the other part that we're always responsible for. So thank you, Dean, for asking an important one, because I did include it, but I did go through all the minutes. Yes.
Yes, I'm wondering, you know, for those of us with children that are afflicted, as you know, we kind of have numerous physicians across everything imaginable. So when I hear you mention Botox earlier and baclofen, within your field, it seems like you're using those to kind of manage the pain. And I'm just trying to contrast that versus the physiatrist, which may use them for a different objective, and as to how you all would kind of work together, if that makes sense.
Oh yeah, no, it does. That because ultimately, when it comes to spasticity, there's two things that are being accomplished, but not both can be accomplished. And also, for some, it's to maximize function, obviously, and for others, it's to maximize providing cares. So, for some children, it's that spasticity interferes with cares. Spasticity is indicating that there's resistance to increasing velocity. So some also good information from therapists can help, because it's maintaining calm and slow methodical approaches so that you're minimizing that abrupt change in body position, which very suddenly brings on spasticity even more so. And then in general, I would categorize spasticity. You either have your calm, comfortable child with spasticity, or your child with spasticity who also has intermittent episodes with pain behaviors. Just all I can say is experientially is that the child with spasticity and this intermittent discomfort, one medication for the spasticity, but rather than layering on more medications directed at spasticity, I would be focusing on medications directed at neuropathic pain as add-on, so that you're also managing that category as a trigger for that alteration in tone intermittently. Children who have spasticity who are comfortable, they tend to respond much better, and it kind of makes sense, they respond better to the medications like baclofen for spasticity, because they also don't seem to have the pain as another trigger for worsening at times. Is that kind of getting at some of your, and then Botox is kind of, again, that combination of, is there an isolated area that can maximize function for an individual, or can it improve cares for a child?
And I guess, no, that's very helpful. I mean, and I guess just as a follow-up to that would be, if the child wasn't experiencing any of that, the pain part of it, you know, I guess then at what point would you determine whether baclofen or Botox, you know, may be of assistance?
Yeah. Or Botox, what's nice is that you get a trial without a commitment. And so then you gain information. And I imagine when you say baclofen, you mean intrathecal baclofen?
Yes, yeah. The type that would be used, you know,
yeah.
for therapy, for example, or to improve spasticity or tone, etc.
Yeah. It really gets down to how good is good enough. Because I will be completely honest, I find of all the decisions I assist families with, this one I find the hardest, because it gets at, is this so unmanageable that we pursue an intervention that has no risk, or can we kind of get by and manage as best possible while we're maximizing the medication side? And I would say that because of that, there's no wrong answer, while balancing that out and knowing that you're always pursuing an intervention with an intended benefit, even if it's the scenario where there is a complication that occurs down the road of, you know, like an infected baclofen pump. It's kind of like, because there's no, I wish there was that equation, but I think having someone you trust to talk out loud with as you're balancing, and acknowledging it is hard to care for children with significant spasticity. No one should feel obligated to have to be Herculean in how they provide care, and look for those interventions that can be really assist with the child's comfort and care as a result.
Yes.
So again, I hope that helps someone. There's not a right answer
Yeah.
for an option.
Thank you so much.
Thanks.
Thanks so much, Julie.
I
So
appreciate
I see you're becoming an honorary member of our group here and work group 4 and our patient portal. And as we, Keith and I know Bob Wyborn traveled all the way from Australia to hear you. So obviously, let's continue this offline as we go. So thanks so much, Julie. So.